Hello, I'm going to talk about anemia. This is an overview of the basics of anemia. So the definition of anemia is that it's a physiologic manifestation of something. It's not a disease process in and of itself. Anemia is something that happens because something else has gone wrong in the body's systems. There can be a variety of symptoms that can happen along the way as the body attempts to compensate for the decreased number of red blood cells. Most of the symptoms that people are mostly aware of include fatigue, pallor. Those are probably the most common ones. As it progresses, there may be some dyspnea and weakness. So the definition of anemia is a reduction in the total number of red blood cells circulating in the blood, and that can be measured either by the hematocrit or the hemoglobin. There's a few things that can cause it. There can be something wrong with the way that the erythrocytes are being produced, like if there is not enough iron or not enough vitamin B12, not enough folate. That can impact the way that the red blood cells are being produced. There can also be chronic blood loss, like if someone suffers a traumatic event and loses blood, they're going to become anemic. There can be also increased destruction of the red blood cells, and that can happen with a number of disease processes we'll talk about later. And there can also be a combination of the three things above. So when the blood cannot carry enough oxygen because there's not enough red blood cells, the body starts to suffer. If you run a CBC, you'll notice that usually the red blood count is low, the hemoglobin is low, and or the hematocrit is low. I have here the normals for anemia in women and during pregnancy and in men. So blood loss. There can be chronic blood loss. That's most often seen in women when there is menstrual bleeding loss, irregular menstrual bleeding, heavy menstrual bleeding. Women can lose a lot of blood month by month by month by month, where eventually the hemoglobin can get so low that they're so weak, finally coming in for care. Because it tends to be sort of a slow blood loss, they're pretty well compensated until it gets very, very low. I've seen women come in with hemoglobin 6, 5, very, very, very low, where if that would have been an acute blood loss, the patient would probably expire with very low blood loss, blood counts like that. But with the slow blood loss, the body is able to compensate for longer periods of time. In men and also in non-menstruating women, the most common cause of blood loss is through the GI tract, some type of GI bleeding. There can be excessive hemolysis of red blood cells. Normally, red blood cells survive about 3 months, and in some conditions, the blood cells are destroyed after just a few days. And there can be a synthesis disorder, like I said earlier. If there's not enough iron or not enough vitamin B12 or folate, then the blood cells are not made correctly. So the symptoms on the different body systems can be impacted in the cardiovascular function. There can be an increased heart rate. You'll see that most commonly. There's not enough oxygen carrying capacity in the blood, so the heart rate goes up. Also, the respiratory rate will go up, and the patient may appear dyspneic. The nervous function can also exhibit some myelin degeneration, and there can be some GI symptoms like nausea, vomiting, or anorexia. This is a picture of a normal blood smear, and on it you'll see a lot of red blood cells. And you'll see most of these are red blood cells, but if you look B, C, and D, those are examples of different types of white blood cells. So you can really see that there's a lot more red blood cells than white blood cell in a normal blood smear. The red blood cells are actually a biconcave disc. It's a little bit hard to see on all of these, but some of them you can tell. I have some other pictures later on. We'll look at this closer. So complete blood count includes hematocrit. A hematocrit is when you take an amount of blood and you put it in a centrifuge, often in a micro tube, and you spin the blood very quickly. And the red blood cells will separate from the white blood cells in the serum. The red blood cells, being heavier, will sink to the bottom or the outside portion of the centrifuge, and the serum will be in the center. And then the white blood cells and other components of the blood make up a tiny little white line separating the two. And the hematocrit is actually a proportion, it's a percentage proportion of the red blood cells compared to the total volume of blood. It's not used as frequently anymore because we have hemoglobin machines that can read the blood. I'm not sure how they do it, in a special way that the meter is able to read the amount of hemoglobin that's in the blood. So most often people are using hemoglobin today. There's also the red blood count, which is where the red blood cells, the number is actually counted, and the indices. I'm going to get into the indices in a moment. So these are the important indices. There are several. The main ones that I'm going to focus on today is the MCV and the MCH, because those are the ones that are most commonly used to differentiate the cause and the type of anemia. So the MCV stands for mean corpuscular volume. Some people call red blood cells red corpuscles. So this is the mean corpuscular volume. It's an old term. The norm is 80 to 100, and that measures the cell size. So a little red blood cell would be called microcytic, and a big red blood cell would be called macrocytic, and a normal sized red blood cell would be normocytic. The MCH is the mean corpuscular hemoglobin, and the norm is 27 to 31, and that refers to the color. So a very light colored red blood cell would be hypochromic, dark colored hyperchromic, normal colored normochromic. The MCHC also exists, and you'll see that on a red blood cell count, but I'm not going to get into that today. So as a general overview, this is how anemias are classified. And this will help you in figuring out what type of anemia your patient has. And then you can figure out the cause of the anemia that your patient has and the best way to treat it. So I have microcytic, normocytic, and macrocytic. And remember, that's the MCV, the size of the red blood cell. So microcytic anemia means small red blood cells. And the main two causes of that, there are other causes, but the main two causes is iron deficiency anemia or thalassemia. Iron deficiency anemia is by far the most common type of anemia, and it's caused by an iron deficiency in the diet. Thalassemia is a genetic condition that I'll get more into further along. So the two most common causes of microcytic anemia are iron deficiency anemia and thalassemia. This chart will really help a lot. If you could mark it down on a piece of paper or print this one slide out, this will help you. Then there's normocytic. I'm going to skip over to macrocytic. I'll come back to normocytic. Macrocytic anemia also refers to the size of the red blood cell, and they're big cells. It's called macrocytic anemia. And you'll also hear it called megaloblastic anemia. Megalo is big, blastic refers to the cells. So megaloblastic anemia and macrocytic anemia are actually the same thing. And they're caused by either vitamin B deficiency, B12, or folate deficiency. So these are nutrition deficiencies similar to iron, except for it causes a large cell instead of the small cell that the iron deficiency anemia causes. Folate is also folic acid. Then into the middle, there's normocytic anemia, and that's caused by acute blood loss. If you think about it, if somebody is perfectly normal and they are in an automobile accident and bleed out a bunch of their blood, they're going to become anemic, but they were not anemic 1 minute ago, or 5 minutes ago. So there really are no changes in the red blood cells. They look fine. There are also some chronic diseases. Probably the most common cause of normocytic anemia is anemia of chronic disease. And I'll talk about that a bit more later. And also chronic inflammation that goes along with chronic disease can be causes of normocytic anemia. So again, if you look at the different, this is another way of looking at that chart, and I have it divided up the MCV into the microcytic, the normocytic, and the macrocytic anemias. And you can again look at those causes. I added, there's a little bit more on this slide than on the chart. The MCH, as I said earlier, refers to the color and how much hemoglobin is in the red blood cell. A low MCH associated with hypochromic anemia, a high MCH is hyperchromic anemia. The reticulocyte count is another value that you will see on the CBC. And a reticulocyte is an immature red blood cell. When we looked at the smear of the red blood cells a few slides ago, there are no nuclei in the red blood cells. They lose their nucleus as they mature. The red blood cells develop in the bone marrow. They go through a variety of stages where they do have a nucleus, and the last stage before they become a mature red blood cell is the reticulocyte, and it does have a small nucleus. When the patient is anemic or recovering from anemia, the body will respond by sending out immature red blood cells. The body realizes there's not enough red blood cells here, we need to pump some out. So some of the immature red blood cells are sent out before they're completely mature. Hence the reticulocyte. So reticulocytes can be a good thing or a bad thing. They indicate generally that the body is responding to the anemia. Sometimes in cases of severe iron deficiency anemia, which is a very common form of anemia, the body can't even send out reticulocytes because it doesn't have enough components to make up the red blood cells. It doesn't have the right parts because there's not enough iron, so there's no reticulocytes. Once that iron starts to get corrected and the patient's taking an iron supplement, the body grabs onto that iron and immediately starts making red blood cells. And as soon as it can, it sends out the reticulocytes. I've seen this a lot in working in women's health when I have women who have had severe menorrhagia with lots and lots of blood loss over long periods of time. They come in, we start treating them with iron. We have them come back, usually in about a week to 2 weeks, redraw their CBC, and we expect to see an increased number of reticulocytes, which would indicate that the body is repairing itself and it's becoming ready, it's getting ready to send out more red blood cells, it's able to make more red blood cells, and you can see evidence of that by these immature red blood cells, reticulocytes being sent out. This is a picture of microcytic anemia. This is actually a microcytic hypochromic blood smear on the left, and on the right is normal red blood cells. So you see these are on the right, they're normal. They're biconcave disc, so what that means is in the center they're thinner, which is why they look kind of pale in the center. But if you look on the left side, the hypochromic microcytic side, they're very pale. There's a bigger area of paleness than on the normal red blood cells on the right. So hypochromic microcytic anemias are most often caused by iron deficiency anemia and thalassemia. They can also be sideroblastic anemia. There can be a problem with iron metabolism. The person may have enough iron, but is not metabolizing it correctly. And it's important to know that thalassemia does not require iron supplementation. In fact, if iron is given to someone with thalassemia, it can cause iron overload with organ destruction. So it's really important if someone has microcytic anemia to do the other tests to figure out do they have low iron stores or not. If they have low iron and low iron stores and microcytic anemia, then you're pretty safe to say that the person has iron deficiency anemia, and you would treat that with iron supplements. If the person has microcytic anemia and they have normal iron and or normal iron stores or high iron, a lot of times it can be high, you do not want to give any iron supplementation. Again, you can cause iron overload, which is very toxic to the organs and can lead to death. So iron deficiency anemia is the most common type of anemia worldwide, and it's related to nutrition. Iron is found in foods. Meat is the most common and easily assimilated types of iron, but it's also in vegetables, like broccoli has a lot of iron in it. Many people think of spinach with iron. However, spinach has oxalates in it, which binds up the iron, so a lot of it's not absorbed. It's not an absorbable form of iron. Broccoli, on the other hand, is very absorbable. Kale is another good one. Another good source of iron are pumpkin seeds, very high in iron, and dark chocolate is another great one. Another good food to get iron from is fortified breakfast cereals. Some of the symptoms of iron deficiency anemia can be brittle or thin, coarsely ridged spoon-shaped nails, a red, sore, painful tongue, glossitis, and sometimes little cuts on the sides of right in the corners of the mouth. So it's symptomatic with a hemoglobin of 7 to 8, and if you remember, in a woman, a normal hemoglobin is 12. In children, especially young children, and during pregnancy, we'll often see iron deficiency anemia. Most babies are born with enough iron to last them about 6 months. After 6 months, babies should start to be fed complementary foods. Babies don't need anything other than breast milk the first 6 months of life. They don't need any types of water, and they don't need any other foods until they reach 6 months of age, at which time you should look for foods that contain iron. That can be meat, that can be some iron fortified cereals. But that's when the babies start to need to get some supplementary iron into their diet. Feeding them complementary foods along with breast milk for a minimum of 1 year, preferably 2 years of breastfeeding. Blood loss is another way, as I mentioned earlier, through the female genital tract, the GI tract, or trauma. So the treatment of iron deficiency anemia, as I said before, really good examples of foods that contain iron are red meat, pumpkin seeds, and high iron cereals. And here's my little blurb about oxalates blocking the iron absorption. I want to talk a little bit about iron supplements. We need 150 to 200 milligrams of elemental iron every day. The addition of vitamin C will help the iron be absorbed. The two of the most common types of iron available over the counter is ferrous gluconate and ferrous sulfate. But if you look at the amount of elemental iron in 325 milligrams of both of them, you'll notice that ferrous gluconate has 36 milligrams of elemental iron, while ferrous sulfate has 60 milligrams of elemental iron. So we might be tempted to say, oh, 60 is better than 36, let's always take 60. But you need to keep in mind that iron causes constipation, causes a lot of constipation. And it's very common for anemia to occur during pregnancy because the mom's body is building an entire circulatory system for the baby, so additional iron is necessary during pregnancy. But if you give her too much ferrous sulfate, she's going to be so constipated, she's not going to want to take her iron, and this is the most common cause, in my experience, of women not responding to iron supplementation for anemia. They simply aren't taking it. So I like to start with a low dose, and I like to use ferrous gluconate maybe twice a day with a vitamin C source like orange juice or tomatoes. Strawberries have good vitamin C content in them. And see how the mom does or see how the patient does. If they're tolerating that okay, you can increase it slowly. But if you start on someone 3 times a day of ferrous sulfate, they're going to be so constipated they're not going to take any of it. And when you ask them, they say, oh yes, I take it every day. And then you find out later, no way, I couldn't stand to take it. So sideroblastic anemia is a condition where there's ineffective iron uptake and the hemoglobin is not synthesized correctly. It's identified by these ring-shaped structures you can see on some of these red blood cells, and they're called ringed sideroblasts. And they are present on bone marrow samples. And the erythroblast, which is one of the forms of immature red blood cells before a reticulocyte, the erythroblasts contain iron granules that have not been synthesized into hemoglobin. So again, this is a bone marrow sample, which is why you see erythroblasts at all. Normally you never see these in the peripheral blood. Thalassemia is a hereditary type of anemia where there's a defective synthesis of the hemoglobin molecule. There can be an alpha and or a beta defect. And what you'll see is a low hemoglobin. That's where the anemia comes from. That's the first thing we look at. Is there anemia? If the hemoglobin is normal, there is no anemia. If the hemoglobin is low, there's anemia. Next step, we need to figure out what kind of anemia is there. Well, if it's microcytic and hypochromic, if you remember from our chart, that's either going to be iron deficiency or thalassemia. The MCV is low. That indicates that it's hypochromic. The next thing we want to look at is the serum ferritin. The serum ferritin is often normal to high in someone who has thalassemia. In an iron deficiency anemia person, that is going to obviously be low. So in in thalassemia, the serum ferritin is normal or high. It's difficult to diagnose alpha thalassemia, and it's often a diagnosis of exclusion, where you test for everything else, it all comes back normal, we make a diagnosis of alpha thalassemia. There's thalassemia minor, and this can be someone who is heterozygous for alpha and the beta. Alpha minor is most common in Southeast Asians, and like I said, it's pretty difficult to diagnose. You just have to figure out some of these diagnoses based on it not being something else. Beta minor is most common in African Americans, people from Africa and the Mediterranean descent, and it's a silent carrier state. Most people have no idea that they have it, and it's pretty rare. But the minor thalassemias on the previous slides are not as dangerous as thalassemia major. Thalassemia major is where someone is homozygous for alpha and the beta defect. Alpha major is the most severe, and that results in hydrops fetalis, and these babies will normally die unless a very intense intervention is done, often requiring a intrauterine transfusion to save those babies' lives. Beta major is also called Cooley's anemia, which can also be fatal. So the heterozygous form of thalassemia minor is not as dangerous as thalassemia major when the condition is homozygous. So those were the microcytic anemias, most common, iron deficiency and thalassemia. I'm moving on to the macrocytic anemias, and also called megaloblastic anemias. And if you see the red blood cells on the left-hand side of this page, those are giant. They're normal chromic, so the hemoglobin is normal, but look at how big they are compared to the normal red blood cells on the right. Macrocytic anemia has a high MCV over 100, and it's caused most commonly by B12 or folate folic acid deficiency. And there's a couple ways to get deficient in B12. One of the most common ways is pernicious anemia. And if you go back to some earlier knowledge, pernicious anemia is where vitamin B12 is not absorbed from the GI tract because of a lack of intrinsic factor. Intrinsic factor is a substance in the stomach, and people with pernicious anemia don't produce enough intrinsic factor to be able to absorb vitamin B12. So they become deficient and they get megaloblastic anemia. The only way to know is it's caused by B12 deficiency or folic acid deficiency is to draw levels on B12 and folate and see what the levels are. A vegan diet can also contribute or cause a vitamin B12 deficiency. Vitamin B12 is found in dairy products, meat, and eggs, and it really is found in animal products. Vegetarians or anyone who eats dairy or fish or eggs has nothing to worry about as far as B12 deficiency is concerned, but vegans do need to worry about it, especially if they're pregnant, because during pregnancy the fetus can also develop B12 deficiency, which can cause some neurological changes. So in vegan, especially pregnant vegans, we want to make sure that they get sources of vitamin B12. And some find that using brewer's yeast is helpful. You need kind of a lot of brewer's yeast, however. There's also some sublingual vitamin B12 tablets that are available that are pretty common now. And that's an easy way to get vitamin B12. You take it under the tongue so it's absorbed directly into the bloodstream, and you don't need the intrinsic factor because it's bypassing the GI tract. There's also injections of vitamin B12 injections. Folate deficiency anemia is most often caused during drug or alcohol abuse, resulting in a loss of a lot of folic acid, and that needs to be replaced. So both of these cause the red blood cells to be manufactured incorrectly, and the anemia ensues. So this is a slide which talks about B12, what's needed for red blood cell synthesis and neuron function, which I already talked about. It's present in animal proteins, and intrinsic factor in the gut is needed. Pernicious anemia symptoms. There can be neurologic manifestations in addition to the typical anemia type symptoms of fatigue and pallor, loss of appetite, abdominal pain. Again, the problems with the tongue. There can be icterus, splenic enlargement. It's often not recognized in older persons, and older persons are more apt to get pernicious anemia. It's more common in older adults and can result in kind of a slow onset of this anemia. So again, the treatment is parenteral, either B12 injections or PO or sublingual vitamin B12. High oral doses of vitamin B12 have recently been shown to be effective, but again, the sublingual doses are also available. Folate deficiency. Normally folate is absorbed in the upper small intestine, and it's not stored in the body. It's water soluble, so we need to have a constant supply of it. It's common to be deficient in the diet in this country. For a number of years now, companies have been fortifying products like juices and breads and cereals with folic acid because it was found that it's very necessary to have this nutrient during pregnancy, during very early pregnancy, the first month or so of pregnancy, when most women don't know they're pregnant yet. It's needed to prevent defects of the neural tube, which can range from spina bifida to anencephaly if it's very severe. And it's really important that women maintain a diet that contains at least 400 micrograms of folic acid every day. And that can be obtained through foods, folate fortified foods, or a supplement. Okay, I'm going to move on to normocytic normochromic anemias. These are characterized by red blood cells that are relatively normal in size and the hemoglobin content, so the size is normal and the color is normal, but there's not enough of them. normocytic, normochromic anemia. Post-hemorrhage anemia, as I said earlier, if you were fine a minute ago and you're in a car accident, lose blood. It's going to be low. Also, aplastic anemia, anemia of chronic disease and inflammation, and hemolytic anemia. All of these lead to normal-looking red blood cells, but not enough. So there can be mild to moderate anemia seen in patients with cancer, AIDS, rheumatoid arthritis, lupus, hepatitis, and renal failure. And it decreases the red blood cell lifespan. There's an ineffective bone marrow response to erythropoietin and an altered iron metabolism. So the body has iron stores but can't use it. There is erythropoietin being made. You have all the components that you need to make red blood cells. The erythropoietin is going, come on, bone marrow, let's make some more red blood cells. And it doesn't work because of this chronic disease, whatever the illness is, that's causing the system to not work effectively. So the treatment is to treat the underlying disease. In some cases, erythropoietin is given, extra erythropoietin is given to kind of jumpstart the bone marrow into producing more red blood cells. Hemolytic anemia means when the red blood cells are destroyed. Normally, red blood cells live for 120 days. They then go to the spleen and are destroyed. And the components of the red blood cell are recycled. The body keeps the iron and reuses it for the next red blood cells that it's going to be making. So sometimes there's an accelerated destruction of these red blood cells. And examples of those are autoimmune hemolytic anemias. For whatever reason, the body just starts attacking its own blood, and the red blood cells become destroyed. Immunohemolytic anemia is another condition, and there's certain drugs that can induce hemolytic anemia. Some people have a very poor reaction to sulfa drugs that can result in hemolytic anemia. There's something called G6PD, and G6PD is an enzyme that protects red blood cells from being broken down by free oxygen. And if a person is born with a G6PD deficiency, they are more prone to develop hemolytic anemia. In fact, it's something to consider whenever giving a sulfa drug. If someone knows that they have a G6PD deficiency, probably a different antibiotic would be a better choice. What I found with this is most people have no idea they have this condition unless they develop a problem from an antibiotic. So always ask what is the reaction people have had from antibiotics. A penicillin type reaction or an anaphylactic reaction is different from a hemolytic anemia type reaction, which can also occur. And patients who have this should probably be referred to a hematologist. I'm going to talk about sickle cell anemia. Sickle cell anemia is an autosomal recessive hemoglobinopathy. It's a big word. It's most commonly found in the United States in people, African Americans, people from African descent. And sickle cell disease, the patient with sickle cell disease has hemoglobin SS, sickle cell. And what happens is the cells, instead of being those nice round biconcave discs that are flexible and can move through the blood vessels, the red blood cells will sickle. They turn into like little C's or little commas. I have a picture coming up. And they clump together and cause a blockage or an infarct to whatever area is distal to where this blockage is. And it causes intense pain. The patients are really, really in a lot of pain, and that's known as a sickle cell crisis. It comes most commonly if the patient is dehydrated or otherwise ill, and the treatment for the crisis is intense pain relief and hydration, and treating whatever illness they may have that's putting their body in stress. When you have someone who's pregnant, one of the tests that we do is check for sickle cell trait. And I have an upcoming slide that shows the genetics of it. But if a mother has a sickle cell trait, we want to find the father of the baby's type. If he has no sickle cell trait, her baby has no chance of developing sickle cell anemia. However, if the mother has a sickle cell trait and the father has a sickle cell trait, there's a 25% chance with every pregnancy of a baby developing sickle cell disease. Genetic counseling should be done, and during pregnancy we want to give prophylactic antibiotics for bacteria. Asymptomatic bacteria in pregnant women is something that we're concerned about because it's highly associated with pyelonephritis and then preterm labor and preterm delivery. So most of the time during pregnancy, in women with sickle cell trait, we do give prophylactic antibiotics during pregnancy to prevent urinary tract infection. It's thought on that last slide it mentions protects against malaria. If you think about why would we have such a condition, there must be some genetic positive about having sickle cell anemia. And what has been found is it can prevent malaria. Patients who are who have the sickle cell trait are more resistant to malaria than people who have normal hemoglobin. However, the 25% chance of getting sickle cell disease is always there. So here's a picture of the red blood cells, and if you can look at that top picture, you see they're biconcave discs, so it's a nice little cartoon drawing, and you could see on the bottom, on the right hand arrow on that top picture, it's kind of going down, and that red blood cell is bending, and you can actually see them. They bend and they fold, and they get through very, very narrow spaces, because when red blood cells exchange oxygen in the lungs and at the cellular level in the capillaries, they're only going by a capillary one cell at a time. So it's very, very small vessels they have to get through. And they do their CO2-O2 magic exchange at that level. So you could see the cross section of the red blood cell. It's kind of squished down in the center. The bottom picture shows the sickled cells. And the person has some type of a stress, often in combination with dehydration, and they go into crisis, and in multiple areas in the blood, these sickled cells start to occur, and they can't fit through the blood vessels. They don't bend, they lose their flexibility, and instead of slipping down those little vessels one cell at a time, you can see they cause a blockage, causing ischemia distal to wherever the blockage is. So I liked that picture. This is a picture of sickle cell. So not all the red blood cells are going to sickle, but you can see where the sickle cells are. Here's one up here, here's one here, here's a couple of them. These look like pretty normal red blood cells over here. We've got a white blood cell, another white blood cell, some sickles, and you can see some of these are biconcave discs on here. This is a kind of a blurred picture. It's a very old drawing that I translated off of an overhead from years ago. But this shows a sickle cell trait positive mother and father. So both the mother and the father have the sickle cell trait. And if you take the capital A, which is the normal hemoglobin, from the mother, and the normal hemoglobin A from the father, you can get a 25% chance of getting a baby who's AA, which is totally normal hemoglobin. You have a 50% chance of getting AS, another two carriers, just like the parents, and a 25% chance of getting a baby with sickle cell disease. So the lab workup for a patient with anemia. First thing you do is look at the CBC report and look at the hemoglobin and the hematocrit. If they're low, the patient by definition is anemic. So anemic means low hemoglobin or hematocrit. Then we need to do a workup. So get the complete blood count, because sometimes only a hemoglobin is done. For example, I work in a student health center where we can do hemoglobins just on a finger stick. If that shows low, we're going to do a CBC. So I get a complete blood count. I look at the MCV, which is my most important indice, and the hemoglobin. I'm then going to look at that MCV and evaluate the results for microcytic anemia or macrocytic anemia. Those are the two most important things. I'm going to get a serum ferritin. A serum ferritin tells me what the patient's iron stores are like. How much iron is stored in the body? What are the reserves? I also want to look at a serum iron and TIBC. I'm going to talk about that in just a second. Consider reticulocyte right away, but you might want to save that if you're trying to save money, which is something I'm always trying to do. I may not necessarily get a reticulocyte right off the bat, but I will like to look at that in the future, maybe in another week or 2 weeks is more common, to see how the patient is responding. And I might want to consider a hemoglobin electrophoresis, which can identify sickle cell anemia or sickle cell trait. So the serum iron and the TIBC, serum iron is how much iron is in the blood. That makes sense. And the higher the amount of iron in the blood, the higher the result is going to show. A TIBC stands for total iron binding capacity, and this little system is a little complicated. The total iron binding capacity indicates how much room is there for iron, how many binding sites for iron is there in the blood. So if a patient has a low TIBC and a high iron, that means all the binding sites are filled. There's not a very big capacity. The total iron binding capacity, there's not much capacity, but the person has a high serum iron. So you would think, okay, they have enough iron and it's filled up all of the binding sites in the blood. Similar to a parking lot. I like to use a parking lot analogy, compliments of Dr. Anita Nelson. If you have a parking lot and you have cars, which I like to think of as iron because they're made out of metal, kind of like iron, and the capacity of the parking lot would be the number of parking spaces in the parking lot. If you have a low capacity and a lot of iron, a lot of cars, that means you have many cars and very few parking spaces. So the parking lot's pretty much full, right? Which is great for health if you're talking about iron in the blood. Not so great if you're late for work trying to find a place to park your car. If you look on the other side, if you have a high capacity, a high iron binding capacity, or a high capacity of parking spaces in your lot, and a low iron or a low number of cars in your parking lot, you have a lot of empty parking spaces. And nobody's looking for a place because every car that's in that parking lot is parked and it's filled up as much as it can, but you don't have enough iron and you have a high capacity. So the results of a TIBC are going to be inversely proportional. When you have a high TIBC, you have a low serum iron. When you have a low serum iron, or when you have a high serum iron, you have a low TIBC in most cases. So again, if you think of it as the binding capacity or the capacity in the parking lot and the amount of iron in the blood, then that is what the TIBC is. When you get both of those values, then you know for sure if it's iron deficiency or not. If it's not iron deficiency, the next test you want to get is going to be a vitamin B12 and a folate level. And you can do those initially. You can get that along with this first round of testing. So here are the values of the serum ferritin, total iron, and the total iron binding capacity. Other tests to diagnose anemia. Hemoccult. You want to look for occult blood in the stool because if the patient has GI blood loss, which is the most common cause next to vaginal blood loss or female reproductive tract loss, you want to find out if there is any blood loss. Serum bilirubin. When the red blood cells are destroyed, one of the byproducts of red blood cells is going to be bilirubin. The bilirubin goes through the bile, becomes bile, You have bilirubin as part of a red blood cell. When it cleaves off and it saves the iron to recycle it, and the bilirubin, it gets rid of the bilirubin. And as that goes higher, the patient can become jaundiced. So you might want to draw a serum bilirubin. Like I said a minute ago, folate and serum B12 to see if you have a deficiency in either one of those nutrients, and a hemoglobin electrophoresis. That's kind of an expensive test, but when you're trying to figure out what's going on, it's a good test to get. Monitoring anemia, once you've treated it, you can repeat the hemoglobin and the reticulocyte count. I have 3 to 4 weeks here. Depending how low the patient really is, if it's somebody like I talked about before with a hemoglobin of a 5, I'm going to have them back there in a week, maybe 2 weeks. I want to follow my patients. It depends how low it really is. If it's a little bit low and they're getting better and you're talking to them on the phone, you can probably stretch that out for 3 to 4 weeks. It does take some time for the red blood cells to be developed. It doesn't happen overnight. And this is just a really nice picture that I like of the biconcave discs of the red blood cells. I hope that this presentation was helpful to you, and I appreciate your listening. Thank you very much.